So for the next 12 minutes, I'll be talking on this interesting topic, war against heart failure, the new weapons in the armory. All of us know heart failure, once sets in, runs a malignant progression. The conventional therapy for heart failure, no doubt, blunts this malignant progression, but despite the guideline-based triple foundation therapy, there is substantial residual mortality that is about 50% at the end of 5 years. Therefore, there is always an ongoing search to have newer and newer weapons in the armory to fight the devil of stroke. But curiously enough, all new weapons in the armory for heart failure only targets HFrEF, and HFpEF, as you had already heard, is still in search of a therapy which could improve its outcome. Now, all of us know neurohormonal activation plays a key role in initiation and perpetuation of heart failure, and we have strong blockers to all the three maladaptive neurohormonal system, the beta blockers for the sympathetic system, the ACEI ARB for the renin-angiotensin, and the MRAs for the aldosterone. And these three blockers, they constitute the triple baseline foundation therapy for HFrEF, and each agent has a class 1 indication. Now, all of us know MRAs was approved way back in 2003, and it took 11 years for the trialists to target the second pathway of heart failure, which is the natriuretic peptide pathway, and which is a favorable pathway. And this was targeted by sacubitril valsartan, and the Paradigm trial was presented in 2014. 2019, we had another revolution with another new weapon, the Sdl T2 inhibitors, and DAPA-HF for the first time showed improved CV outcomes in patients with HFrEF, and this was followed by Emperor reduced in 2020. Sdl T2 receptors are the molecule of the decade. Then we are having another weapon which is being evaluated, that is the vericiguat, which was tried in the Victoria trial, and this year we had this positive trial. And we have omecamtiv mecarbil, which again, the top line results from the Galactic HF recently has shown positive results. Whenever we are treating heart failure, it is very, very important is that every hospitalization, every rehospitalization takes the patient closer to death. And therefore, one of the important messages in heart failure is prevent hospitalization for heart failure, prevent rehospitalization for heart failure. And indeed, all the new weapons which we are going to talk are powered to do it on top of guideline-based triple foundation therapy. Now, when we look at the evolution of therapies for heart failure, we have the perisacubitril era, as you can see. RAS blockers and beta blockers were approved in 90s, 2003 MRAs were approved, and 2014 kicked off a new era of sacubitril valsartan with Armory, and we had the Paradigm trial in 2014, and this agent, sacubitril valsartan, was approved for chronic HFrEF in 2016, and we have the Pioneer HF trial in 2019, and this agent was approved for ADHF in 2019. So we had an additional pillar for heart failure HFrEF with the addition of Armory. 2019 initiated dawn of a new era when we have the first Sdl T2 trial, DAPA-HF, which showed positive CV outcome, and DAPA was approved for HFrEF, and this year we had the Emperor trial. And all these Sdl T2 inhibitors were already approved in past for decreasing hospitalization for heart failure, but not for treatment of HFrEF. So DAPA-HF laid the first foundation stone for utility of Sdl T2 inhibitors for treatment of HFrEF. And in fact, with this, we had the fifth pillar of heart failure, and DAPA for the first time smashed the boundary between diabetic and non-diabetic drugs. Being an anti-diabetic medication, it shows similar benefit in diabetic patient, and it has opened a new pathway for heart failure management. Sacubitril valsartan, as we know, thrown a new concept of multi-system neurohormonal modulation never heard before. The second unique feature of sacubitril valsartan is that it achieved a class 1 recommendation to replace a class 1 ACE and ARBs. It rarely happens in the history of pharmacotherapy that a new drug is given a class 1 recommendation to replace a class 1A drug. Usually it is given as an add-on therapy, and all of you are aware of that it shows a very statistically significant reduction in HFrEF on top of the conventional therapy, a 20% reduction. And both the individual endpoints also showed a statistically significant reduction. You can see cardiovascular death is decreased by 20% on top of standard therapy. The mortality benefit with sacubitril valsartan are pan-mortality benefits, whether it is all-cause, whether it is cardiovascular, whether it is sudden death, or worsening heart failure. All mortalities are reduced on top of guideline-based recommended therapy. And the benefits in heart failure hospitalization are 21% reduction, and as you can see, all-cause mortality also a 16% reduction. It results in lower likelihood of multiple hospitalization, and as we know, every hospitalization is very dangerous. Fewer days in intensive care with ARNI, as you can see the data. And we have Sdl T2 inhibitors, another new weapon in the armory. And these are the three front runners, AMPA, CANA, and the dapagliflozin. All these agents after 2015 have been approved for decreasing hospitalization for heart failure after these landmark trials, the AMPA-RED, the CANVAS, and the DECLARE. And DAPA laid the foundation stone by DAPA-HF trial for treatment of HFrEF. And this is the design of the study, DAPA-10 compared with standard of care. And you can see the positive results. Primary endpoint, cardiovascular death hospitalization for HF and RHF decreased by 26%. Look at the NNT, 21. And the individual endpoint, CV death, 18% reduction, and worsening HF event, 30% reduction, and also all-cause mortality. There were three very key messages from DAPA. The first big message from DAPA was that the drug is effective in non-diabetic HF also, and there's no issue of hypoglycemia. Data has shown you can very safely give it in non-diabetic. The second big message was that DAPA-HF shows incremental benefit on top of ARNI, and that is also very exciting. The third big message is with DAPA coming in vogue for HF, it is poised to change the definition of refractory heart failure. Prior to DAPA-HF, whenever we diagnose refractory heart failure, submit a patient for a device like LVAD or cardiac transplant, we always say, have you taken ARNI or not? If not, go and take ARNI and come back. Now we'll say, have you taken ARNI? And now we'll say, you have to take DAPA also. If not, go back and take DAPA and then come back. So it's poised to delay device therapies like LVAD and transplantation. And you can see the earlier you start DAPA in class 2, more is the benefit. Then we had the EMPEROR trial, which showed equivalent results in patients for decreasing hospitalization for heart failure, but there was no significant difference in the cardiovascular death or the all-cause mortality compared to DAPA, where it scored over the EMPEROR residues. The mechanism of action of SGLT2 are multifarious, as you can see on the slide. More important than that is that it acts and definitely acts and improves the outcome of patients of heart failure. One of the interesting mechanisms is that it decreases interstitial edema, and this is one of the reasons why it is speculated that trials of DAPA, the DELIVER trial and trials of EMPEROR, the EMPEROR preserved may become out positive, because if the interstitial edema is decreased, the hypertrophic fibers or the fibrotic fibers in HFrEF will be able to relax better. And this is one of the reasons why people are speculating that trials with HFrEF will come out to be positive. So SGLT2 DAPA has done the formidable task of improving CV outcomes in HFrEF on top of the other pillars of a weapon. And therefore, it is a very exciting new weapon in the army to fight the devil of stroke. And as you can see, Sdl T2 inhibitors, particularly DAPA, which is proven, can be used across the continuum of heart failure. You can use in stage A heart failure, prevent, you can use in stage B, C, and even stage D. One of the important new messages coming from heart failure treatment is never treat heart failure in isolation, never treat kidney failure in isolation, because there is a close cardiorenal continuum. heart failure and CKD are intimately linked, and there's bidirectional interplay between them, which means if heart failure worsens, kidney failure worsens, and vice versa. So always, whether you are treating heart failure or CKD, treat cardiorenal continuum as a whole for comprehensive treatment. And it is now believed, rather it is true, that if you treat CKD, it targets benefit it triggers benefit for heart failure. And that was perhaps the missing link, which now we have realized. The other reason is that when we are treating patients with HFrEF, please focus on CKD, and because they slow down the trajectory of chronic kidney disease. I'll show you in a minute. The normal decline in eGFR is 0.9 ml per minute per year. When patients develop diabetic CKD, the GFR falls roughly 10 ml per year. And prior to the RAS era in the early 20th century, many of these patients were submitted to dialysis and transplant. But the first revolutionary era for CKD came with RAS blockers in the early part of the first decade of the 20th century, and they decreased the slowing GFR from 10 to 4.59 ml per year. And the second revolution actually was kicked off in 2015, but documented after the Curated trial in 2019. And this produced an additional improvement in the declining GFR from 4.9 to 1.85. And you'll be very glad to know we are now amidst the third upcoming revolution in CKD. The Fidelio trial with non-steroidal MRAs is positive, and this has the interesting feature of this is, unlike the first two strategy, which targets kidney by hemodynamic changes, this targets fibration and inflammation. So in future, the prognosis of CKD is going to improve tremendously. The normal decline being 0.9, after dual therapy is 1.85, and if you use top of the finerenone, it will make phenomenal difference. Look at this, unbelievable but true. CKD trial is this canagliflozin trial. Credence slowed down the declining eGFR, and you postponed dialysis by 15 years, which is indeed a very, very great achievement. And therefore, my message for heart failure treatment, we as cardiologists, when we are treating, please remember 7 reasons why all cardiologists must also focus on kidney, because CKD is easy to detect, proteinuria GFR is simple tools to detect, trajectory of CKD can be slowed down tremendously, SDL1 has greater efficacy on top of RAS blockers, and CKD detection and treatment saves the heart. If you want to save the heart further, also target CKD and target kidney. Targeting kidney triggers benefits in heart failure. And this was the missing link which we have missed for several years. So what is the current status of Sdl T2 inhibitors? We have canagliflozin, which showed decreased hospitalization in the CANVAS trial. We have the Curated trial, which laid the first foundation stone of Sdl T2 inhibitor cana for patients of diabetic CKD. Then we have the EMPA, which showed decrease in cardiovascular death for the first time, a documented cardiovascular death reduction, and the EMPA trial, which showed decreased hospitalization for heart failure, but failed to show reduction in cardiovascular death and all-cause mortality. And we have the DECLARE trial, which has data in primary and secondary prevention, which has data in HFrEF diabetic and non-diabetic, and the DAPA CKD, which has data in diabetic and non-diabetic CKD. So DAPA is little ahead of the other agents, although we do not have head-to-head trial. But instead of comparing the trials with different SGLT2, more important is the message that these agents are life-saving. They are very, very safe. They are practice-changing molecules. They are guideline-changing molecules and cost-saving. And we must disseminate the benefits of SGLT2 widely. The medical fraternity is not sufficient to disseminate. You should also utilize various social media and change the outcome of the patient. And we not uncommonly hear that after use of SGLT2, the patient say, "You have really changed my life." And this is again very interesting. The overall survival projection in a 55 years old male, if you use all the 4 agents, which means beta blockers, ARNI, MRAs, and SGLT2, you can increase the projected lifespan by 6.3 years, even at the age of 55 years. And this is indeed very interesting. The other new weapon in the Armory is vericiguat. And as you can see, this is an oral soluble guanylate cyclase stimulator that directly enhances the cyclin AMP pathway. this pathway gets blunted due to endothelial dysfunction and decreased nitrous oxide. But to the right, you can see if you directly stimulate this, there's more cGMP production, which protects the heart and the vasculature. And this was a trial which carried out in chronic HFpEF with worsening. And you can see the positive results, a 10% reduction on top of all therapies, statistically significant. Look at the NNT, 24. Cardiovascular death was not improved, all-cause death was not improved, and this is the summary of the trial. And the important messages from the Victoria trial: NNT 24 is once daily medication, easy to titrate, safe, well tolerated, without the nuisance of monitoring renal functions or electrolytes, and in future this will be approved. And lastly, we had the omecamtiv mecarbil, which is a novel selective cardiomyosin activator. And the benefits of this agent is it acts in a peculiar way, increases duration of systole, increases stroke volume without any increase in the myocyte calcium, DPDT, or myocardial oxygen consumption. So it doesn't have the danger of inducing cardiac arrhythmias. The GALACTIC-HF trial was ongoing, and we had the top-line results on the 8th October. The trial met the primary endpoint and is positive. The secondary endpoint were, of course, not met in terms of cardiovascular death. So what is the take-home message? Heart failure, one sets and runs a malignant progression. The two new weapons in the armory to target the devil of stroke are sacubitril valsartan and DAPA. AMPA is not yet approved, but will be approved, and they produce great benefits. So what is the big message? Utilize all 4 drugs: beta blockers, ACE/ARB/ARNI, MRA, Sdl T2 for HFrEF, as they provide incremental benefit. Never hesitate to use all the 4 drugs, although the sequence of initiation may vary. So if possible, all these 4 drugs should be on board, though the sequence of initiation may vary, and all therapies should be escalated. Heart failure in diabetic, 85% death at 5 years should be escalated. One should not think of de-escalating even if the patient is stable. Polypharmacy is the rule, like malignancy, AMI, and other diseases, and patient should be motivated to accept it even he's not having much symptoms. And very, very important, the neurodevelopment, target cardio-renal continuum and not treat HFrEF alone. In fact, targeting CKD triggers benefit for HFrEF. And the other new weapons, which are still in the process of evolution, not yet approved, have shown exciting data in the trials, that is the vericiguat and omecamtiv mecarbil. Thank you very much for your kind attention.